Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello, welcome back to Top Med Talk. I'm Andy Cumpstey, I'm your host again, and it's a real pleasure this time to be joined by two leading surgeons from the UK, Mr. Christian Macutkiewicz and Mr. Dimitris Damaskos. So thank you both for joining us here on Top Med Talk. Christian, can I come to you first? Could you maybe introduce yourself to our listeners, tell them a little bit about what you do, what your roles are in the UK at the moment?
I'm Christian Macutkiewicz. I'm a consultant general ASGBI and hernia surgeon in Manchester. I've previously been involved with the Association of Surgeons of Great Britain and Ireland as the director of the scientific program, which is what Dimitris is now. And I'm very honoured to now be the president of the ASGBI for the next 2 years. And it's a real privilege to be able to do this role. From a clinical point of view, I've been chief of surgery in my hospital and I've led lots of service transformation projects. So I've done quite a few of those sort of projects in my life. And my clinical roles changed quite a bit from being an advanced pancreatic surgeon when I was in Leeds to now being a general surgeon with more of an interest in benign gallbladder and complex biliary disease and abdominal wall reconstructions and hernias. So that's my background.
Fantastic. Huge experience. Thank you very much. And can I ask you the same question, Dimitris?
Yes, thank you very much. Thank you for the invitation. I am Dimitris Damaskos and I am a general surgeon based in Edinburgh. As Christian already mentioned, I am the director of scientific program for ASGBI. I do a practice in emergency surgery and abdominal wall reconstruction. And as a result of that, I'm also involved with the British Hernia Society and the World Society of Emergency Surgery.
Fantastic. So lots of experience and topics we could dive straight into there. Just as a starter for 10, our listeners will know that on our recent episodes, we've covered lots of things such as preparing patients for surgery with surgery school, lots of things about intraoperative management, how we get that right and sometimes wrong, and things we can improve. But I think it's fair to say that the post-operative space is, if not the most, definitely up there as one of the more important of those three sections of the perioperative journey. From a surgical perspective, how do you view the post-operative period of care and what are the, key challenges to getting a patient through that period successfully?
Shall I kick off? So from my perspective, I actually think the post-op period is probably the most important bit, not just to keep a close eye on a patient. Obviously, it depends on the difficulty or complexity of the patient's care. But even so, even if it's just a hernia repair or a gallbladder, it's the post-operative bit that really matters to the patient. And I think the thing that we don't do as well is the post-op communication. We often do ward rounds very quickly. We don't explain things to patients very well. And so I think that's a focus in my practice, to actually make time to sit down to patients, draw them diagrams of what we've done during the operation and explain why any complications may have occurred. I find that doing that really helps the patient to understand what's happened, because it's quite a nebulous thing having surgery and not really knowing any anatomy or knowing really what we do. So I think that's the biggest thing in my practice, is making sure that patients are kept informed, sort of experienced in the post-op period. I'll let Dimitris have a bit of a go. I don't want to hog the whole thing.
Well, I would add to that. I think mostly I would emphasize what you mentioned, Christian. So we tend to spend a lot of time with patients that I've like to think in a way that had complications or have had a difficult operation, which, I assume they are the minority for all of us, but we tend to kind of go through very quickly the patients that had a successful operation, even those patients need reassurance. And even though the procedure itself was successful, still things can go wrong, unexpected complications. So it's very important to keep them in the loop. And even in those patients that we are reassured that they don't well fine, to keep a close eye. And the second thing, which is part of the current surgical literature, is the so-called term of failure to rescue. So a systems-based approach which enables us to recognize patients deteriorating. This is an ongoing debate, quality improvement program, call it whatever you like, depending on which side you're looking at it from. But the essence being that there needs to be a system in place that is able to recognize the patients deteriorating on the ward or in intensive care in a consistent way.
Both excellent points. I think, as you both mentioned, complications. I mean, and you're right, Christian, for a patient hearing that, I mean, that's, for us, it's so much bread and butter. These complications happen, we know that. But it must be quite alarming when it's you experiencing that, and communicating that must be a challenge. But I mean, how often are complications occurring, and what sort of complications are patients experiencing?
So I don't want to alarm anybody by saying that there's complications happening all the time. And I think complications are rarer and good outcomes are most often. I think there are a few things that I want to pick up on what Dimitris has said, because I think one of the things that have been slightly missed in clinical practice is the actual art of examining and picking up signs and identifying that patient that's not quite right. And I'm old, I'm 51, so I'm used to examining a lot throughout my practice and in my career. And I've noticed during the years that juniors are not as confident in picking up signs of complications or knowing what they're examining and relying on ultrasound and CT scan. Now, obviously, CT scan's more accurate than my hand, but just having the knee-jerk reaction of going straight to CT or straight to ultrasound, I think has lost a bit of the art of clinical medicine. And it's one of the things I really enjoy teaching on my grand round on a Friday. So I do a ward round on a Friday, which picks up all the complications. In terms of how do you handle it, complications don't happen all the time, but when they do, it really is a massive psychological hit on the patient. They heard the word complication and they think, oh my God, I'm going to die, or I'm going to have a horrendous outcome. So it's so important to explain to them why it happens, what you're going to do about it, and what the usual time frame is to resolve a complication. I'll explain one patient that actually happened just before I went on holiday in Cyprus, and that's why I'm looking all relaxed. A really difficult perforated appendix that required a laparotomy, and it was a young lady who's on the medical wards for a week without a diagnosis with sepsis, and they didn't know what was going on. Eventually, after a week, they got a CT, and the CT showed a horrendous pelvic abscess and probable appendicitis. And that's certainly what I found when I did the operation. And I left a drain, and she went into an ileus, and she had post-op collections. And it was the day after surgery, I explained to her what happened, and I gave her the probable prognosis of 30% chance of having an intra-abdominal abscess post-operatively. So because of that, she was kind of expecting it. And so she wasn't afraid of when it happened. And I'd said to her, this is how we're going to deal with it. I showed her a CT scan. I explained why you get collections. So I think having been a patient myself, I think that's probably what changed my perspective, because I was very much kept in the dark and it was very frightening. And I certainly don't want my patients to experience that sort of thing.
To that, I would add, we shouldn't be unfair to the surgical training program. I think you know better than I do that there is increasingly more focus during surgical training on the non-technical skills of being a surgeon. This is something that we have perhaps not been teaching very well. Well, certainly when I trained, it wasn't part of the curriculum or even part of the discussion. So I think we have progressed. And I think it is telling that more and more organizations in the UK, at least, tend to include patients in their executive boards or as part of advisory groups. And I think maybe we're not just there yet, but definitely there is more awareness of the fact, really, that what we're doing for the patient and for us.
And I think we all agree that although these complications do happen, it's a small number of patients that sadly get them. But I think it's well recognised that that small number with complications are a really big burden for healthcare systems. And we all know a patient that goes through surgery and leaves hospital very quickly afterwards actually costs the health service in financial terms a lot less than even a few days extra length of stay, as well as you both highlight the individual burden or scariness of being that patient who gets that experience, which puts, I guess, extra pressure on us to identify them early, whether that's with clinical examination or the CT scan or both, and then manage them promptly. But I guess there's also a pressure there to try and prevent these things from happening in the first place, isn't there? And try and keep patients as safe as we can. Obviously, no one wants the complication. But how do you see clinical practice changing over the short, middle future in terms of things that are going to come in to maybe affect that post-operative period, help keep patients safe in that period, to try and prevent these complications? What sort of things should we be looking out for?
Do you want to go first, Dimitris?
Yeah, the one thing I would say is that the post-COVID period has actually had a significant impact. We all know on many things, but I think what I have seen is that this understandable priority to clear the lists, but that has led to patients not necessarily being operated by the surgeons who have actually seen them in the first place. And that can be the first mark of problems, if you know what I mean. I'm not saying problems will happen, but it is kind of an easy way that the system has permitted, because of all the pressures, for us to be more vulnerable and for the patients to be vulnerable to these issues.
Yeah, good point. It's start, we talk about the Swiss cheese model, don't we? The holy cheese model going through the human factors. And so many of those little things can happen that seem small at the time, but actually have a big impact on the patient. Christine, anything you want to follow on from that?
I mean, it's something that's very much happened in the UK. I'm not sure it's the same in other countries. I can't imagine it's the same in the US, where I think an attending would operate on the patients that they've seen. The problem that Dimitris has highlighted is you make your first impression and first relationship with a patient when you see them in the clinic or when you see them on the post-tape ward round, and you strike up that relationship and you start to gain their trust. And when you do get a complication, you've already got a bit of trust and a relationship with the patient. And so it makes it a lot easier to break the bad news. It makes it easier for them to understand because they've already got a relationship with you. So when you meet them on the day and operate and you get a complication, that sets you back from a communication point of view. Where do we see the future? All different countries have different systems. When we used to have a firm structure in the UK and you had your own juniors and everybody went round together, there was a culture of picking things up early, speaking to your immediate seniors and getting things sorted as a team. And that's sort of been lost a little bit. And I don't think I ever see that coming back. But we have to flatten the hierarchy to make sure that our residents are doing ward rounds independently, but backed up by consultants, because that's how they learn to pick up the early signs. And a lot of residents, junior residents in particular, are not doing so many ward rounds, so not picking up those skills of picking up the patient that's going off subtly. Having the consultant available to speak to and advise is really important. And that's where flattening the hierarchy is really important. I think the elephant in the room is AI. I know that there are lots of AI projects looking at stratifying post-op CTs and giving a probability of ischemic bowel and things like that. So I think AI will have a role in the future. Whether it has a role in diagnosis is also an avenue that I think it probably has a role, in terms of you put lots of numbers in and it gives you a probability of appendicitis or something like that. So I think AI is something that will touch all of our practice, and it's up to us to marry it up with the clinical science, because there's no AI model that's going to have a hand. And I think that's where we're not going to be put out of a job quite yet.
Yeah, very good point. And I think you're absolutely right. The AI question is going to come in. We're going to have to manage that some way. I just want to come back to the point Dimitris raised earlier about the failure to rescue. And that's a really key point in this area. Dimitris, maybe we can come back, pick up on that point again. Do you want to explain a bit more about what that term means and put into context maybe for our listeners who are not UK based?
So the failure to rescue is a concept that has been there for ages. The actual reality of it is not a new thing, but it's more about the recognition that patients that have a non-normal postoperative period tend to give early signs of that happening, or even late signs that are ignored. And the well-functioning units are the ones that do high volumes of specific cases, and then are able, just because of that prior experience, to understand early whether something is going according to what is the expected postoperative plan or not. So the point being that if you want either your operation to be a success, or even if it is a complication, because there's going to be a complication in some patients, to have this procedure done, ideally, if circumstances, local, national, whatever you may call it, allow, to have a unit where this particular type of procedure is done in numbers, because that's what allows the unit to pick up the complication earlier.
I think to go along with that is the high volume units often have enhanced recovery after surgery protocols, which really helps to guide the residents and nursing staff to pick up early signs. For instance, with colorectal cancer, ERAS in our institution has day 3 CRP, and if it's over 150, they automatically get a CT abdomen and pelvis with contrast, and that's to look up early signs of anastomotic leak. So I think ERAS protocols have really helped with that, but it does require a unit to have unity to be able to all adhere to the same thing. So that's why not everybody has an ERAS protocol.
And do you think, coming back to the AI topic, do you think AI is going to potentially help that process by able to pick up deviations from the norm a bit faster? Or is there a risk that by doing that, we further threaten the clinical experience, clinical training of our residents?
I think that's inevitable. AI bot picking up that there may be an early sign of leak using heart rate, pulse rate, respiratory rate, temperature, and CRP undoubtedly will de-skill us in picking up the early signs from a clinical perspective. But there's no doubt that that will probably be more accurate. And so that's a good thing for the patient. I just have a little bit of nostalgia in my mind that is quite nice when you do examine and you pick up the early signs yourself. But, you know, not everybody likes examining. And so AI is probably going to remove part of the job that some people don't enjoy. And as long as it's validated, I'm sure it'll be better for the patient.
I mean, I would also add to that, Andrew, if you don't mind. We have As an organization, ASGBI, we have focused a lot over the last couple of years on remote monitoring. So the role of a new technology to kind of monitor the patient's vital signs continuously. And, that technology, has existed for a while, but what hasn't existed, I guess, is its more wide application. And second, all this data, continuous monitoring of vital signs over thousands of hours, and the interpretation of this data to find trends that you can identify patients that deteriorate. I will also quote Julio Mayol. He's a friend of both Christian's and mine. I hope he's listening. So he did have a great presentation, and he showed the photo from Star Trek where the doctor was just holding a little tablet, And then he said, are there actually doctors in Star Trek? No, they're not. A part of our weakness is that we always want to strive the best to get to zero complication. And for that, people make mistakes. So the machines need to come into some of that. So that would be our success and our failure at the same time, I guess.
Yeah, again, for listeners listening to this episode, we did a series on Top Med Talking with some experts on that continuous remote monitoring setups from London. And I commend anyone to listen to that episode. It was really interesting to hear about. On the face of it, sounds like a very simple piece of technology to put someone with continuous monitoring on and see what happens. But actually, the data governance around that, being able to integrate the different signals, the additive effect you get with changes in multiple variables simultaneously. There's a huge amount of work we still have to do in that area to make that work. But it's a really exciting area of medicine that's going to come into our practice almost inevitably, hopefully sooner rather than later, but at some point in the future. Yeah, it'd be interesting to see how that feeds back to your point, Christian, there about communicating with the patient. Because I think, yeah.
As part of the ASGBI, we're very privileged to have strategic partnerships with multiple medical technology companies. And we've been very fortunate, Dimitris and I, to have first-hand look at some of this technology. And it's amazing. And it certainly does have the potential to really pick up early signs that somebody's not very well, maybe even days before we would pick it up clinically. So I think there's no doubt that there's lots of good to come out of that. The GDPR and data handling mess, which I'm not clever enough to understand, is the thing that they will have to work through, certainly with our different healthcare systems. I think the NHS would struggle to purchase anything like that. The private sector would probably be the first avenue that would have this. Obviously, in the States, it would be different. And certainly in the private areas of Australia and New Zealand, they will also have it in a different way, whereas the public, I think, will not be able to afford it as much. It will remove or reduce clinical acumen, and that is sad, but, as that's progress.
And I guess I'm just watching the time, Sally, but changing tack slightly in the last few minutes, I've got to ask, whilst I've got two expert surgeons online with me, and I say I'm an anaesthetist, intensivist, not a surgeon, but robots, are they the way forward? Are they here to stay? Are they making a difference to patient outcomes? Or are they just extending my anesthetics?
Oh. Shall I start? I'm actually on one robot, so I use one of the robots. I'm not going to advertise any robot companies. It's a nice toy. It makes me more accurate. It's certainly finer. The picture's better. The 3D quality's better. So it certainly makes a difference in terms of dissection, I think. Does it make me more efficient? No. Does it allow me to do some of the difficult things laparoscopically that I wouldn't be able to do with a straight stick laparoscope? Yes. And so I think it does have a role, but I think it's more on the more difficult end of the spectrum than routine gallbladders or routine hernias. But obviously people have to learn, and they have to learn on the simple stuff to be able to do the difficult stuff. And so if you look at the UK, I would say we're 10 years behind the US from a robotics, and they've gone through that. And so they're doing emergency stuff robotically. They're doing nearly everything robotically. And I know they have a different system, and so they can afford that approach. I think the UK will have a slightly more nuanced approach. It will be more for the difficult, close pelvic or hiatal, or certainly 2-quadrant operating in the abdomen. It's got a huge role in abdominal wall reconstruction, and there's lots of emerging evidence that abdominal wall reconstruction is probably a really good thing for the robot. I might leave Dimitris to continue with that bit. I've been very fortunate to be in New Zealand when they were talking about bringing the robots in. This was at the New Zealand Association of General Surgeons meeting in Auckland this year. And yeah, so they were really discussing the health economics of bringing in robots to the nation and how much it would cost and what the benefits were. And there's one unit doing high volume robotics in Auckland, but everywhere else in the country don't have one. And so it's quite an interesting discussion from a national perspective to listen to them discuss the pros and cons. I still keep in touch with my friends in New Zealand, and I know that they've bought more robots nationally. So I look forward to going back next year and seeing what the progress has been. But I think it's a very sexy thing. Surgeons like toys. We've got to think about training, and we've got to think about our residents. And so we've got to learn from other nations that have brought it in on how they've rolled it out to their residents. And I think it's inevitable that we will have it all.
The only thing I would say to what Christian said is, obviously I agree with everything he said. The only thing I would add is that surgeons that are highly proficient in robotic surgery, and I'm not one of them, I would say that actually the robot is a continuation of open surgery. So a lot of them advocate that from open, you go straight to robotic, that laparoscopy is not really a necessary step in the process, which obviously is great. And Christian said is correct. Better optics in the 21st century, we talk about precision medicine, and I guess robotic approach to surgery is part of that. But the wide applicability of it remains a significant issue.
All good points. And that's probably a good point to finish this episode on. But thank you both very much for joining us again here on Top Med Talk. For the listeners at home, as always, you can find us on our website, through social media. If you do listen to us on social media, please do hit thumbs up. It really makes a difference to us being able to stay open access and free at the point of listening. And to that end, we should thank our sponsors again this year for making that happen. And this year, that's BD and GE. Thank you very much for listening.
Top Med Talk.
Top Med Talk is the broadcasting arm of EDPOM, evidence-based perioperative medicine. Join clinicians from around the world at EDPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to edpom.org. That's edpom.org.